Hi guys, my first syndrome I'm going to be talking about from the reading is Goldenhar syndrome. This is a congenital condition with no known cause. Congenital meaning children are born with this condition. This causes children to have ocular dermoids and external ear deformities. For example, preocular skin tags, or having no external ear at all. This is an example of a dermoid. It is a growth on or around the eye. Some cases of Goldenhar syndrome include Duane syndrome, lid, iris, or choroidal columbomas, deafness, or vertebral abnormalities. This is an example of a columboma of the iris. This is basically a tear in the tissue, so as you can see here, there's a chunk of the iris missing. Dermoids, as we talked about earlier, can cause corneal astigmatism, meaning patients need to be refracted at every visit to their ophthalmologist. Limbal dermoids in particular can cause amblyopia, and this is because of the obstruction of visual axis or by creating a bad astigmatism in one eye. Amblyopia is a type of poor vision. It usually happens in one eye, and the eyes can no longer work together because of the poor vision from one eye, and that eye tends to turn off. Our next syndrome we're going to be talking about is Mobius syndrome. This is either a unilateral or bilateral congenital syndrome. Again, congenital, meaning from birth. This happens when 6th nerve palsy and 7th nerve palsy combine. 6th nerve palsy affects the eye muscle control. The eye is not able to turn outwards. 7th nerve palsy affects the facial muscles. This causes facial paralysis to one side of the face. Mobius syndrome causes an esotropia. Again, the eye will turn inwards nasally and it will have a hard time or an impossible time turning outwards. It also causes limited abduction, inability to form facial expressions, and in some cases, the inability to fully close the eyelids. It is important to note that vertical or up and down movement of the eye is unaffected. The extreme esotropia does require surgery, and the surgery is aimed to move at least one eye to the primary position. This allows the patient to fixate without a large head turn. And in young patients, they need to be monitored for amblyopia.